Greetings, everyone. I hope you're doing well. We would like to welcome you all in our webinar with Dr. Stephen Morgano. Dr. Sami Farsi, can you hear me? Dr. Sami, you can start unmuting your mic, please.
Okay.
Yes, the mic is yours.
Thank you very much. It is with great honor and pleasure today to introduce a very special presenter, Dr. Stephen Morgano. Dr. Morgano is professor and chairman of the Department of Restorative Dentistry at Rutgers School of Dental Medicine. He is a diplomat of the American Board of Prosthodontics and former professor and director of the Division of Postdoctoral Prosthodontics at Boston University School of Dental Medicine. This is where I had my training, and I would like at this opportunity to thank Dr. Morgano, really. He was a great mentor, a great supervisor and teacher. And I would say that on my behalf and on the behalf of all his Saudi students, which probably you know at least 10, 15 of them here in Saudi, his passion for teaching have inspired all of us. And it's funny that we memorize several of his sentences and phrases, and we keep saying it during our teaching. So we are very honored to be trained by such an amazing personality and an amazing professor. Now, Dr. Morgano has published over 75 journal articles in the professional dental literature and 14 textbook chapters, which I know all of them maybe have their artwork. He's an artist and he draws all the artwork himself. The presentation that he will give us today was the backup presentation at the February 2020 Scientific of the American Academy of Fixed Prosthodontics in Chicago. So I would like to take this opportunity again to thank him for gracing us by accepting our invitation. And let's all enjoy this amazing presentation. Thank you, Dr. Morgano.
Thank you, Dr. Sami. Can you hear me?
Yes, loud and clear.
Thank you for your very kind words. I'd like to thank the Saudi Prosthodontic Society and the president and Dr. Ishki and everybody for having invited me. So let's get this going here. Can everybody see the screen?
Yes, doctor. Nice. Nice.
Okay. Thank you very much. So welcome everybody, to all my colleagues and friends in the Middle East and to everybody else. The presentation we're going to have today was my backup presentation for the last February meeting of the American Academy of Fixed Prosthodontics. They didn't need to use it, so you guys are going to see it for the first time. No one else has seen it. All right.
Dr. Steve, if you can just tap on the slide by the mouse after you enlarge it, and then press the left or right button or enter.
Oh, I see.
Yes, I think now you can use your keyboard to switch between the slides.
Okay.
You can go.
So post and core, the topic is very controversial because it's so complex. There are so many different variables that can influence the prognosis of a tooth restored with a post-in core. So we're going to play a little game here. I'm going to make some statements, and then I'm going to ask myself, is this a myth or is this a reality? Then I'm going to review the evidence as best I know it, and I'm going to come up with an answer. So I have no interest in anything here. I have no conflict of interest, no financial interest, nothing. So you may have seen this sentence, and it is attributed to Mark Twain, a very famous American author. Everybody talks about the weather, but nobody does anything about it. And we can say the same thing about evidence-based dentistry. A lot of people talk about it, but not so many people do much about it. So we're going to review the evidence as best I know it for the restoration of pulpless teeth. Now, if we look at this review, Goodacre did a review on complications in fixed prosthodontics, and he had a small little section on teeth with post-in cores. And this review included 12 clinical studies. And what he found with this review was that there was a 10% mean complication rate with post-in cores. And these were traditional metal post-in cores we're talking about. The number one reason for failure was post-dislodgement, and that was 5% of the 10%. And the second most common reason was the root fractured. And then 2% was everything else, including reinfection of the apex, recurrent dental caries, and other things. So if we look at the traditional recommendations for restoring a pulpless tooth with a post-in core, we would like to conserve 4 to 5 millimeters of apical gutta percha. We would like the post to be at least as long, if at all possible, at least as long as the clinical crown. And then finally, we would like a ferrule. Now in English, the word ferrule means an encircling ring. So we would like the margin of the crown to extend apical to the margin of the core by 1.5 to 2 millimeters minimal. So that's the minimal amount of ferrule. Now, do these traditional recommendations still apply? We're going to find out. So my first statement, the presence of a ferrule is probably the most important variable for a tooth restored with a post-in core. Is this a myth or is this a reality? So the idea of a ferrule is not a new idea. Frank talked about the crown tying an endodontically treated tooth together. Rosen talked about the hugging action of a crown. But it was Eisman. He's deceased now, but he wrote a chapter in Pathways of the Pulp, which is a classic endodontic textbook, and he was the first one to come up with the word ferrule. Now the ferrule does 4 things. The ferrule will help reduce the potential for the root to fracture. The ferrule will also help reduce the potential for the post to fracture. It will reduce the potential for post-dislodgement, which, as we remember, was the #1 reason why post-in cores fail. And then reduce the potential for failure of the cement seal of the overlying artificial crown. Right, so if we look at the studies on root fracture, and there are many in vitro studies, these are just a few. But if we look at the artwork to the right, we can see this red arrow is the occlusal force that's directed to the crown. We can also see that there's very little remaining tooth structure. If I didn't build this up with a post-in core, this tooth would be non-restorable technically. But what's holding this core in place is the post. So these occlusal forces, they're resisted by the core, but they're transmitted into the root as a spreading force. So basically this root is subject to fracture because the post wants to fracture the root. And what stops this post from fracturing the root is the fact that the crown encircles coronal tooth structure for 360 degrees, helping to protect the root from fracture. Now, post-fracture. Chubb Joyner did a study, 788 posts, 72 failed. And this was actually one of the studies that was in Goodacre's review. And of those that failed, 46 were dislodged posts, which is about 6% of the total number of failures. But of the teeth where the post fractured, and there were only 6, but of those teeth where the post fractured, there was no furrow. So if we look at the biomechanics, the artwork to the right, if the margin of the core and the margin of the crown are at the same cervical level, occlusal forces are resisted exclusively by the post as it exits the post preparation. And with time, under dynamic loading, we could get fatigue failure and the post could fracture. Now, if we look at dislodgement, that's the #1 reason why posts fail. So if we look at the artwork to the right, Kaufman did a classic study on retention. And the way retention is measured, the crown is cemented and then it's pulled off. The amount of force required to pull it off gives me the retentive value. The higher the force, the more retentive the crown will be. And what Kaufman found was that most of the retention from a crown preparation comes from the cervical third of the preparation. Now we have built this tooth up, and we've built it up to improve retention, and it does improve retention. But more importantly, it improves resistance. Now the way resistance is measured, it's all or none. Either I have it or I don't. I will seat the crown on the die, and I'll push the crown in all directions. If the crown does not rotate off the die, the crown has resistance. And we need them both. But again, now let's look at the artwork all the way to the right. If I have cervical tooth structure, then part of the retention from this crown comes from the cervical tooth structure. If I have a margin of a crown and a margin of a core at the same cervical level, all the retention from this crown comes from the post, and the post is more likely to be dislodged. And then finally, there's the cement seal of the artificial crown. Libman and Nichols did a study that was in vitro with post and cores and crowns overlying the post and core stored tooth, and they dynamically loaded the teeth. And they found the taller the furrow, the less potential for leakage of the crown. And then Kovarik did a study, which we're going to talk about in the next slide, where he found that the type of core material can also affect the integrity of the cement seal of the crown. So if we look at the artwork all the way to the right, okay, the red arrow is my occlusal force. So if I have a core material that has some flexibility, and if I have a post that's not rigid, there is potential for micro movement of this core, which can cause the cement seal, the small red arrow, to fail. And of course, the problem is I won't know that the cement seal has failed because the crown is still cemented. So by the time I realize that the cement seal has failed, there's advanced caries. Now, if we look at Kovarik did an in vitro study of premolars. And they had a prefabricated post, parallel-sided serrated post, and 3 different core materials. Silver amalgam, composite resin, and then silver modified glass ionomer cement, which is Keetac silver. There was a crown on top, small furrow, crowns were dynamically loaded. Key-Tack silver, all the cores broke down with dynamic loading. Composite resin, all the cores flexed with dynamic loading, and the cement seal failed. The only core material that really held up when there was a minimal furrow was the silver amalgam. Now also, Fan has shown that the design of the posting core can influence the integrity of the cement seal of the crown. If I have a two-rooted maxillary first premolar, where the post will not be in the center of the root, but either to the facial or the lingual, what he found in vitro under dynamic loading, if the post is in the facial root, there's more potential for the cement seal on the lingual to fail. If the post is placed in the palatal root, it helps to reinforce the cement seal and avoid failure. And then Freeman has shown, once we get leakage, we're going to get bacteria ingress between the crown and the tooth structure, and we will get caries down in the canal. And when I was the director of prosthodontics at Boston University, we had 24 residents. We had a big, big, big operation. A resident would come to me and say, Dr. Morgano, I took this post out of a tooth and this caries in the canal and it's not restorable. I know it was a prefabricated post with a composite resin core and very little furrow, because that's how they fail. So most of the studies in the past were in vitro studies. It wasn't until a little less than 20 years ago that we really got some good prospective studies. And the advantage of a prospective study is the investigator controlled the treatment. So in vitro studies are okay, retrospective studies are okay, but prospective studies are really the best. Now this study by Elner, he had 50 teeth, and each tooth had a 2mm furrow. He knew that. But the best part of the study, the teeth were followed for 10 years. Now, the way he designed the study, he had 4 groups, and the idea was that they would be randomly divided with 4 different post systems. CPC is cast post and core. GPP is a gold parapost with a core that's cast against it. BOPP is a burnout pattern for a parapost with a resin pattern adapted to it, and then it is invested and cast. So these are the 3 cast systems. RA was a radix anchor post. A radix anchor post is a threaded post, and it's not commonly used in the United States. Now, what they discovered, they couldn't randomly use this radix anchor post. The head is unusually shaped, and there were some teeth where it just wouldn't work. So they just picked 10 teeth that they knew it would work, and then they randomly divided all the other teeth between the 3 upper groups. Now, if we look at 10 years, the cast post and core, 0 failures. The gold parapost, 0 failures. The burnout parapost, 1 failure. The radix anchor post, 2 failures. So if we look at the overall failure rate, it's 6%, which is not bad compared to good acre. But if we exclude the radix anchor post, it's not commonly used in the United States, plus it's a threaded post. Threaded posts have been shown to be more prone to failure. So if we just look at the cast post systems, failure rate was 2.5% over 10 years. Now, when you think about it, what's the success rate of a crown after 10 years? Now, Kruger's did another prospective study, a lot more teeth, 219. Now, it's only 5-year follow-up, but it's a very interesting study. Now, what they did initially, they divided up the teeth into 2 groups. If there was enough coronal tooth structure to make a furrow, they put that in the group called substantial dentin. If there was minimal tooth structure, so that we couldn't get the minimal ferrule, they called it minimal dentin. Now, the idea was with substantial dentin, they were going to divide the teeth into 3 groups. One group was cast post core. One group was prefabricated posts with composite resin core. And then one was composite resin core without a post at all. Now, if you look at the numbers under substantial dentin, they're not random, obviously. Composite resin core is only 42. So what happened was, teeth that were supposed to have a composite resin core only, the dentist got nervous and added a prefabricated post for some of them. So that's why the prefabricated post is 90. Now, if we look at the minimal dentin, they didn't plan on doing any composite resin cores without a post. So this is true randomization. Now, if my only variable of interest is substantial dentin, which is a ferrule, versus minimal dentin, which is not a ferrule, then the lack of randomization with substantial dentin really doesn't spoil the results. Okay, so if we look at the teeth with substantial dentin height over a 5-year period, success rate was 98%, so they had 2% failure. Now with minimal dentin, the success rate was 93%, so they had 7% failure. Now if I make a conjecture, which is purely conjecture, that we're going to have a similar failure pattern over the next 5 years, the ones with a ferrule would have a 4% failure. The ones without a ferrule would have a 14% failure. And these results are statistically significant. Now, this is a study from the endodontic literature. And what they did was they evaluated teeth over a period of time, and they knew that the teeth had a ferrule because it was prospective. Now, they never mentioned the height, but I'm assuming that the literature is very clear that 1.5 to 2 millimeters is the absolute minimum. So they had cast post and cores 6.2 years, prefabricated posts with composite resin cores 5.2 years, and then teeth without posts. So the post is there only to hold the core. If there's enough tooth structure to retain the crown, the tooth doesn't need a core. The tooth doesn't need a post. All right, so the survival rates adjusted for 5 years. Cast post and core 97.1, prefabricated posts 92.5, teeth without posts 94.3. So all of these had a fairly good survival rate over a 5-year period, and they all had a ferrule. Now there are these fiber posts that we're going to talk about. They are stretched fibers in a resin matrix, usually epoxy resin. The original ones were carbon fibers, they were black. The newer ones are either glass or quartz, and the posts are white. And the theory behind these posts is they have a flexibility that is similar to dentin, and they will help protect the root from fracture. So some have suggested that perhaps we could avoid worrying about a ferrule if we use one of these carbon fiber posts, because the post will flex just like the tooth structure. So this particular study had a 3-year follow-up. 45 teeth had a ferrule. 42 teeth did not have a ferrule. So after 3 years, the teeth with a ferrule, failure rate was 6.67%. That's not so bad, but it's only 3 years. But look at the teeth without a ferrule. Failure rate 26.2%. So 1 out of 4 failed. And of course, the problem is the authors forgot the ferrule does 4 things. It doesn't just protect the root from fracture. It does 3 other things. So I'm going to answer my question. The presence of a ferrule is probably the most important variable for a tooth restored with a post-in core. Is that a myth or is that a reality? That's a reality. My next statement, longer posts improve the prognosis of restored pulpless teeth. However, post and molars should be restricted to 7 millimeters. Is that a myth or is that a reality? All right, so let's look at the research that's available. Now, this is a very old study by Sorensen and Martinoff. It's a retrospective study, but it's the best data that we have on length of posts. If the length of the post equaled the length of the clinical crown in their study, failure rate was 2.5%. If the length of the post was 1/4 the length of the clinical crown, 10 times the failure. The failure was 25%. So if we think about it, a shorter post will be less retentive, but also the biomechanics will be unfavorable. If the post equals the length of the clinical crown, any force on the crown is transmitted to the root 1-to-1. If the post is 1/4 the length of the clinical crown, because of the laws of leverage, any force on the crown is transmitted to the root by a factor of 4. So 4 times the forces. So again, the two most common reasons for a post to fail, post dislodged or the root fractured. Now, Fuss did a study of teeth that had already fractured that had posts, and he found the majority of the posts were very short. And just to show how people get confused about post-in cores, Cohen, who was the editor of Pathways of the Pulp, which is a classic endodontic textbook, published an article in 2003 showing teeth that had already fractured. And in his discussion, he said that the reason that these teeth fractured, the posts were too long, too wide, or both. Well, none of them were too long. Some of them were too wide, but none of them were too long. So I wrote a letter to the Journal of the American Dental Association with literature suggesting that longer posts have a better prognosis. And the author responded saying, "Thank you very much, Dr. Morgano, I learned something new." So if the editor of an endodontic textbook isn't really clear on the biomechanics of post-in cores, is there any wonder why it's a confusing topic for a lot of people? All right, so here's an example of a very short post. Now this post is less than 1/4 the length of the clinical crown. Now if you look at this radiologic lesion, this is called a J lesion. And this is the classic lesion that we see when the root has fractured. So this is the extraction, and there is the fracture. Now with molars, the biomechanics are really quite different. And the length that is recommended for the post is also different. Abu Ras did a study, 150 extracted maxillary mandibular molars, and he prepared post preparations with number 2, 3, and 4 size piezo reamers. And what he found, mesial roots and mandibular molars should be avoided. The root is curved. There's also a concavity on the distal surface that's not visible on the radiograph. So potential to perforate was high. Avoid buccal roots of maxillary molars for a similar reason. They're curved and there's concavities that are not visible on a radiograph. He also said never use anything bigger than a number 2 piezo reamer. But he also found that apical to the orifice of the canals in the distal canal of the mandibular molar and the palatal canal of the maxillary molar, after 8 millimeters, there were concavities, again, that could not be seen on the radiograph, and the dentin became thinner. So he is suggesting limit the length of the post for a molar to 7 millimeters apical to the orifice. So longer posts improve the prognosis of restored pulpless teeth. However, posts and molars should be restricted to 7 millimeters. That's a reality. And what about apical seal? A 4 to 5 millimeter apical seal of gutta percha must be preserved. Is that a myth or is that a reality? Now, there are many leakage studies, and the classic leakage studies suggest 4 to 5 millimeters. Now, people have complained that leakage studies are not all that reliable. And the Journal of Endodontics, they no longer publish a leakage study. However, we've been using this guideline for decades, and it has withstood the test of time. And if we look at, again, the reason why post and cores fail, reinfection of the apex is way down on the list. So I would say that the use of this guideline of 4 to 5 millimeters of gutta percha is rational. So a 4 to 5 millimeter gutta percha seal must be preserved. That's probably a reality. Now, coronal coverage. Coronal coverage is recommended for posterior teeth. Is that a myth or is that a reality? Now, if you look at Sorensen's study, it's the same one where they looked at length of posts. Now, they evaluated 1,273 pulpless teeth. And what they found was a posterior pulpless tooth without a restoration that covers the cusps. Failure rate was very high, depending on the location in the mouth, anywhere from 40 to almost 50%. They didn't find that with anterior teeth. Anterior teeth that could be restored with composite resin did just as well as those that were restored with crowns. Aquilino and Kaplan also did a retrospective study, and they didn't separate the teeth out into anterior or posterior. They just looked globally at whether the tooth was endodontically treated and had a crown or not. And what they discovered was a tooth that was endodontically treated without a crown, 6 to 7 times the potential to fail. Now here's a study on 220 pulpless molars that never got coronal coverage. Now if we look at the success rate after 1 year, not bad, 96%, 2 years, 88%, 3 years, 5 years, 36%. Now the variable that was most significant was remaining tooth structure. But even with remaining tooth structure, they looked at the success rate of molars with just a class 1 restoration, just an access preparation. After 5 years, the success rate was 78%, which means 22% failed after 5 years. So if we look at coronal coverage, you can see the artwork way to the right. That crown is encircling the tooth structure. And remember, Rosen talked about the hugging action of the crown. Frank talked about how the crown would tie the tooth together. So without something that covers the cusps, there's potential for this tooth to fail. And when the tooth fractures, it never fractures favorably. So coronal coverage is recommended for posterior pulpless teeth. That is a reality. Now, next statement. Bonded restorations can substitute for coronal coverage. Is that a myth or is that a reality? So this in vitro study evaluated endodontically treated extracted teeth in vitro. Group A was amalgam restoration, MOD. Group B was a bonded MOD inlay. Group C was a metal onlay cemented with zinc phosphate cement. They loaded these until failure, and the onlay cemented with zinc phosphate cement was the strongest. The weakest was the silver amalgam, and the bonded inlay was in between. Now, there's not so many clinical studies on bonded inlays, but this one by Stoll was a study on bonded Empress inlays. And they separated out the inlays that were endodontically treated. And the probability of success was 53%, which means almost 50% failed over a 5-year period. So the conclusions were currently the restoration of non-vital teeth with inlays is not recommended. So bonded restorations can substitute for coronal coverage? That's a myth. Okay, fiber reinforced posts, we briefly mentioned them. Fiber reinforced posts have a modulus of elasticity similar to dentin. Because they can flex like natural tooth structure, the prognosis is better when compared with a rigid metal post. Now keep in mind, Goodacre found a 10% failure rate with classical rigid metal posts. Is this a myth or is this a reality? Right, these were the original fiber posts. They were introduced more than 20 years ago. They're epoxy resin with carbon fibers. Now remember Kovaric's study. He found that composite resin cores flex and they can tax the cement seal of the crown and produce failure. Now what about if I have a composite resin material that flexes attached to a post that also flexes? It seems to me we're going to eventually have problems. But let's look at the literature. We made these posts, but they were black. They were black. People wanted to use these posts, and they wanted to use them on anterior teeth where they were going to place all ceramic crowns. So they asked the manufacturer, could we have aesthetic ones that are white? And of course, they're going to give us whatever we ask for. So there are newer ones that are made with epoxy resin usually, but the fibers are either glass or quartz. Now, if you look at this box here to the right, I've covered up the name of the company. If you look at that tooth that's going to be restored, it's got one of these fiber posts, and the entire preparation is composite resin with virtually no ferrule. This is a very unfavorable substructure for an all-ceramic crown. Now, one of the problems with these fiber posts, especially the white ones, they're not very strong. Now, the manufacturer says, oh, if they break off, you can get them out very easily. Well, if they're going to talk about breaking off, it must be a problem. But maybe the black ones we can get out easily because we can follow the black dot. But these aesthetic posts, they're translucent. They take on the color of the surrounding dentin. They're very difficult to see. So this patient came to us. This is actually from Boston. Another dentist put this fiber post in. We didn't even have them in the clinic. And it broke off. So we told the patient, technically the tooth is not restorable. We will try to get it out, but we might perforate. And if we perforate, we didn't make a mistake. We just did the best we could. And you can see the photo to the right. We perforated. Now here's a fiber post that we wanted to get out. So we gave it to the endodontic resident. And the endodontic resident tried to get it out using a microscope. This was the result. So I don't believe these posts are easy to get out. All right, so let's look at the studies. The oldest study that I'm aware of is a little more than 20 years old, and it was Fredrickson. And she used those carbon fiber posts, and it was a group of 7 dentists, and there were 236 patients. The follow-up time was 32 months. And she reported no problems, not a single problem of any of those teeth. But if the problem is what we see to the artwork on the right, she didn't follow them long enough. Now here's one of those aesthetic posts. These are quartz fiber posts, again, followed for 30 months, failure rate 1.7%. But 30 months is not long enough. So Segerstrom did a study. Remember that Frederickson study? He took a subset of her patients. So 5 of those 7 dentists allowed him to follow their patients. And there were 99 patients, and they were followed for 6.7 years. So more than double the amount of time. And again, this is the same group of patients, but just a subset. Success rate was 65%. 32 teeth were extracted. 3 posts were dislodged. Of the 32 teeth were extracted, 14 because of tooth fracture. But these posts are supposed to guard against tooth fracture. 14 because of root fracture, almost half because of root fracture. Also, there were 9 incidences of recurrent dental caries, which they didn't even count among the failures. So if we add the caries, the failure rate was 44%. For the same group of patients that had no problems. And again, we keep seeing the same picture. This is one of the problems with a post that is flexible. Now here's another study, and this one is prospective. The one by Segerstrom was retrospective. Glass fiber posts, so those aesthetic posts, those white ones, they were observed for 10 years, 149 teeth. This is a very good study. Annual mean failure rate was 4.6%, which means after 10 years, 46%. Now they didn't mention whether a ferrule was present or not, so we don't know. What they did discover was anterior teeth were twice as likely to fail compared with posterior teeth. Now this study by Chang, it was in vitro, but he evaluated in vitro the cement seal of an overlying crown under dynamic loading when the post was rigid metal or when it was one of these fiber posts. And the rigidity of the post definitely influenced the success of the marginal integrity of the crown. Again, so remember Goodacre's numbers. 10% mean complication rate with traditional metal posts. Now, the 2 long-term studies that I showed had failure rates of over 40%. So, fiber reinforced posts have a modulus of elasticity similar to dentin. Because they can flex like natural tooth structure, the prognosis is better when compared with rigid metal posts. That's a myth. So we recommend rigid posts. Now what about cements? These are all the cements that are available to us. Zinc phosphate is the oldest cement. Comprimer is not commonly used for posts, but I included it just for completeness. So, the next statement. Resin cements will provide better retention for posts compared with conventional cements. Is that a myth or is that reality? Now, while we're on the topic of cements, there is a cement, and it's a very good cement, but it's not recommended for post-encores. Resin-modified glass ionomer cement is a hybrid between traditional glass ionomer and resin. Now, glass ionomer is a water-based cement. Because it's a water-based cement, the resin has to be hydrophilic. because the resin is hydrophilic, it will imbibe water. As it imbibes water, it will expand. So most manufacturers do not recommend this cement for all ceramic crowns. And potentially, if this expansion can crack an all cement or all ceramic crown, it can crack a root. Now, Gordon Christensen did a study. He filled glass pipettes with resin-modified glass ionomer cement and just left them in water. And eventually all the pipettes, the glass fractured. Now, it took months for it to happen, but eventually they all fractured. So no one's ever proven that this cement can cause the crown to fracture, the ceramic crown, or the root to fracture. But why take a chance when we have other cements that are just as good? So are resin cements really better than conventional cements? So these are some studies on the retentive strength of a resin cement versus zinc phosphate cement. The first study saw no difference. Second study, the resin cement was more retentive, but the last three studies, zinc phosphate was more retentive. And one of the things that we have to remember is the setting characteristics of these resin cements. All dental resins are incompatible with eugenol. Eugenol poisons the setting reaction, and they never really set. Endodontic sealers. Most endodontists use endodontic sealer with eugenol because they like the handling characteristics. The whole process of endodontic treatment is to force the sealer into lateral canals and the openings of the dental tubules. So when I do the post-preparation, how do I know if I got all that eugenol out? The answer is I don't. So probably more important than the cement that we use is our cementation technique. So if we look at the artwork all the way to the right, if I put cement only on the post and just place the post into the post preparation, as soon as the liquid cement touches the opening of the post preparation, I'm going to trap air. That air has no place to go except through the cement film. So if we look at the study to the left here by Jacoby and Schillingberg, they cemented posts using clear plastic analogs in vitro. And they just put it on the post only. When they cemented the post, they could see the cement film. And it was about a third air. Then they entered the cement into the post preparation first using a Lentulo spiral, then covered the post with cement, and they didn't have air voids. Now, to Jan and Nemitz, they compared Panavia cement, which is a resin cement, to glass ionomer cement, and they had very disappointing retention with the Panavia cement. But when they pulled these posts out, they found air voids, again, about a third of the cement film. So Fakia has done a study, and it's a really good study. What he found was, if I inject zinc phosphate cement into the canal first, using this Jiffy tube, which is to the left, then I use a Lentulo spiral to make sure that it's adapted to the walls, then coat the post with cement and seat it. Dramatic improvement in retention. Just placing the post on just placing the cement on the post only, and then using these two devices, the Jiffy tube and the Lentulo spiral, improved the retention by almost 3 times. So what we're recommending, scoop up cement. We're recommending zinc phosphate cement because it has excellent working time. Gives me plenty of time to pick up the cement into the Jiffy tube, inject it into the post preparation, use the Lentulo spiral, and then seat the post. So we're recommending scooping up zinc phosphate cement with the Jiffy tube. Carrying the Jiffy tube right to the bottom, squeeze and remove the Jiffy tube to fill the canal with cement. Then use a Lentulo spiral to ensure that it's well adapted. And this is based upon a study that's a long time ago. So resin cements will provide better retention for posts compared with conventional cements. That's a myth. Now those fiber posts, which I don't use, these are designed to be cemented with resin cement. And the manufacturer recommends a self-adhesive resin cement like Reliax Unicem. All right, conclusions. 360-degree ferrule effect is probably the most important thing to think about when restoring an endodontically treated teeth with a post-dent core. Length of the post is important. We would like the length of the post to equal the length of the clinical crown. Got a purchase seal, we need 4 to 5 millimeters. Now, if there's a conflict, if getting the post as long as I want it will violate the apical seal wins. We're not going to violate the apical seal. Coronal coverage. Posterior teeth should have a restoration that covers the cusps. Now, this restoration can be an onlay. It doesn't have to be a complete crown. We're recommending rigid posts. But the cementation technique is more important than the cement. If I followed the rules, if I made sure that I have a ferrule, if I make the post as long as practical, if I use the technique that Zaki Fakir showed us, and I use zinc phosphate cement, the potential for this post to come out is very, very, very low. So traditional principles, they do still apply. Now, we talked about look at studying endodontically treated teeth, there's so many variables. It's difficult to isolate one variable and avoid confounding variables. And sometimes we just have to use common sense. Some things, they just can't be tested. And some things are so obvious, they really don't need to be tested. All right, I'm going to give you a couple seconds to read this. This is a real article. Do I really need a randomized controlled clinical trial to prove that jumping from an airplane with a parachute is a better idea than jumping from an airplane without a parachute? And where am I going to get volunteers for this study? So here's a Pros resident. He was crazy enough to jump from an airplane with a parachute. Imagine how crazy he'd have to be to jump from an airplane without a parachute. And sometimes we have to admit to our patients, not every tooth is worth saving. Now, if we look at the artwork here, this single implant supported crown and this 3-unit fixed partial denture to the right, the literature shows the prognosis is very similar. So the choice is based upon other factors, such as, do the teeth adjacent to this edentulous space, do they need a crown anyway? Is there enough bone for the implant? So we make this determination, again, based on common sense. So traditional principles, they do still apply. Thank you very much. All right. All right, so we have a bunch of questions here.
Yes, thank you very much, Dr. Morgano, for this beautiful, beautiful presentation. I'm sure everybody enjoyed it as much as I did. It just brought me back almost 2 decades when I was a resident at your school. And if you've seen during the lecture, all the artworks there have Dr. Morgano's signature on it. And we used to ask him any question. I would just go to the board and do a beautiful artwork. And then he will explain everything on the drawing that We don't have to use our imagination. Everything is right in front of us. So thank you very much again. And for the audience, you will see on the screen the question for the lecture. You can log into the Twitter account and post your answers. And now, Dr. Morgano, thank you. He will try to answer some of the questions. There is many of them, so he will do his best to answer as much as he can. Thank you again, Dr. Morgano.
Okay, the first question, silver amalgam. Yes, silver amalgam is the strongest, and it's especially useful when you have the minimal furrow. Now, people talk about 1.5 to 2 millimeters. That is the absolute minimal threshold. Okay, when I have a long root but no furrow, how much furrow in millimeters should I tell the orthodontist to extrude for a post on 4? Okay, that's an excellent question. So there's no tooth structure above the soft tissue at all. So we'd like 2 millimeters above the soft tissue. Now with extrusion, there's a relapse and it's going to come back usually about 1 millimeter. So we would ask the orthodontist to extrude so that there's 3 millimeters above the soft tissue. Okay, it's okay to leave more than 5 millimeters of gutta percha in the canal. Yes, it's okay to leave more than 5 millimeters of gutta percha in the canal if the post is as long as the clinical crown. If leaving more than 5 millimeters of gutta percha will make the post shorter than the clinical crown, it is best if the post is longer. Okay, so when there is vertical height less than 2 millimeters, they classified these teeth without a furrow, because I think minimum is 1.5. Well, we say 1.5 to 2 because the finish line on a crown is not exactly at the same cervical level all the way around. So a lot of times on the proximal, we have 1.5, and then we have 2 on the facial and the lingual. Okay. What is the recommended post length for anterior and premolar equal the length of the clinical crown? Okay, length of post in molars, 7 millimeters from the orifice. So wherever the orifice starts, go down 7 millimeters and then stop. Okay, so the question is, if you don't have a furrow, what do you recommend? And of course, not having a furrow doesn't mean the success rate is 0. But the patient has to be informed that the prognosis is questionable. Also, there's a study by Debacker that showed that if the tooth is going to be a single crown, the prognosis is better than if it's going to be an abutment to a fixed partial denture. And even if you look at fixed partial dentures, 3-unit fixed partial dentures are better prognosis than fixed partial dentures longer than 3 units. Okay, so the next question is on endocrowns. And there's not so much literature, although there's more than there used to be about endocrowns. And there's one very recent study that showed that an endocrown that incorporates a 1 millimeter furrow has a better prognosis than one that has no furrow at all, that has just a butt joint. And Malament, he does lithium disilicate cores that he bonds in molars and then puts a lithium disilicate crown on top. So it's basically the same concept. Okay, regarding post length, if we have a long maxillary canine, what should be the post length? Again, the post, it's best if the post equals the length of the clinical crown. Longer posts have a better success rate. Okay, what factors do you consider when making a choice between an amalgam core and a cast metal core for an endo-treated molar, which you're planning to place at full coverage crown? Okay, I personally do not use cast post-in cores on molars. I feel that an amalgam core is a better restoration because I can retain the undercuts. And retaining the undercuts helps retain the core. To do a cast post-in core, I have to remove all the undercuts. And I'm removing tooth structure. And if we look at toughness, toughness by definition is resistance to fracture. And the toughness of dentin is directly proportional to its bulk. So we would like to save as much tooth structure as possible. If I have enough pulpal chamber to retain the core, we don't need a post at all. If I need something to augment the retention of the amalgam core, that's when I will add a post. I'll use a prefabricated post. Actually, parallel, prefabricated post, parallel. Okay, regarding coronal coverage, is it recommended even if the tooth is premolar with only access opening in a young patient? Again, the research shows that any posterior tooth without coronal coverage has a much higher chance of failure. Now, again, the success rate is not going to be zero. And the patient has to be made aware of that. But if we look at the tooth in the patient that has the most potential to fracture, whether vital or not, it's a maxillary first premolar. We cannot use onlay or overlay for posterior endodontically treated teeth. Yes, we can. Any restoration that covers the cusps has improved the prognosis. Would anterior tooth, if had a post, can tolerate to be used as an abutment for a bridge? Yes, it can. It can. But the chances of a problem, especially if we have minimal furrow, will be higher if it's an abutment to a fixed partial denture compared to serving as a single crown. Okay, what is the best way to get a furrow and why? If there's not enough coronal tooth structure, we basically have two options. One is to extrude the tooth. The other is to do crown lengthening. Now, we don't want to do surgical crown lengthening if the tooth next to it is an implant-supported crown, because we don't want to take bone away from the implant. In that situation, we would want to do extrusion. Now, if the root is very short, that's probably not going to work, and maybe we just have to recommend that the tooth is going to have a questionable prognosis at best, and think about an alternative to doing post-in crown. So what is the major problem with glass fiber reinforced post in the case of retreatment? Okay, I assume you mean retreatment endodontically. And the problem is that they're difficult to get out. The endodontists hate to get them out because they can't see. They're translucent and they're like a chameleon. They just blend in with tooth structure. So we can't see where the post begins and ends and where the dentin begins and ends. All right, the study for fiber post failure. His teeth on that study was crowned well. The answer is no. These people that did the studies, these are well-known dentists. All right, what about the Ferrari 2012 study? Yeah. Ferrari has different results. And people could say, well, I cherry picked those two articles with the failure rate of over 40%. And I did. I did, because I have very alarming results. And if we look at most of the studies, the follow-up time is 3 years or less. And I think all of us expect that our restorations are going to last more than 3 years. Okay, what about bonding metal or ceramic onlays? Yes, yes, that is perfectly fine. It's inlays that are the myth. Right. What clinical features that influence your choice of core material for a cuspal coverage restoration on a lower right 6, lower right first molar, which has been endodontically treated? Now, if there's an abundance of tooth structure, the core material doesn't matter. If more than 50% of the height of the preparation is natural tooth structure, then the core material doesn't matter. If we have minimal remaining coronal tooth structure, then the core material does matter, and silver amalgam is the preferred core material. Right, can you comment if there's any problem using resin modified glass ionomer cement for all ceramic crowns such as Emax or zirconia? Okay, zirconia, because of its strength, we can use any cement, it doesn't matter. Okay, Emax is best cemented with resin cement, etched and bonded with resin cement. Okay, do I think that with bonding technology that the resin bonding technique can make the ferrule a myth? There's not really enough information on endocrowns just yet. And like I said, there's a recent an in vitro study where they found that the restoration is stronger if there's a ferrule incorporated with the endocrown. Okay, so the first question is, what's the best post and core for anterior teeth? And there is one study by Carosa, and what he found was that if I use a yellow gold cast alloy post and core and polish the facial surface, the ulcer crown will not be discolored. And then Malament, now Malament has the largest data set in the world on ulceronic restorations. And what he's found in his data set is that an anterior tooth restored with a cast gold alloy post and core has a better prognosis than an ulceronic crown on natural dentin. And it makes sense. The cast gold alloy post and core is rigid. Now, the success rate in the restoration of an anterior tooth with just access preparation, the answer to that is just place composite. There's no reason to place anything other than composite unless there is an aesthetic problem and the patient needs a crown anyway. Okay, in which situation do you recommend the use of a fiber post? Basically, the fiber post works best when you don't really need a post at all. When there's a lot of tooth structure, the fiber post is going to be fine. When there's minimal ferrule, my feeling is the fiber post is not as good of an option. And remember, the study by Naumann, anterior teeth had about twice the failure of posterior teeth when fiber posts were being used. Hello, Adnan. All right, what is the best cement for a post? And that's an excellent question. Glass ionomer cement, one of the problems with glass ionomer cement it's very soluble too, but that's not such a big problem. The fact is it's weak. So if we try to use the handpiece after we cement the post, the vibration could disturb the cement set. So we're recommending zinc phosphate. Zinc phosphate is easy to use. It mixes different from any other cement, but anyone can be taught to mix it. It gives you plenty of working time to do all the things we talked about. Within an hour, it reaches 75% of its maximum strength. So it has a short setting time. Can I get the lecture recording? I think that they recorded it. I'm pretty sure. I gave them permission to record it. So I'm pretty sure that.
Yes, yes, doctor, it is recorded indeed. It will be on our website later on.
All right, same question. Can we use glass ionomer cement for posts? It's probably not the best cement because of its peculiar setting characteristics. All right, what's the best type of post? I assume he's talking about a prefabricated post. I use a parapost, parallel-sided serrated post. I only use them in molars, and I only put them in either the distal root of a mandibular molar or the palatal root of a maxillary molar. I put them 7 millimeters from the orifice. Are fiber posts really that bad? This is what we were taught to use at university. I don't use them. All I'm talking about is what I see in the literature. But a very good friend of mine teaches at a dental school, and he told me, he says, you know, we use these fiber posts all the time. And he said, you need a picture of a failed fiber post? He said, I got plenty. But again, if there's abundant tooth structure, it doesn't matter. Okay, what about the remaining tooth structure to decide when we can do a fiber post and a cast post? Again, it's the same question. If there's an abundance amount of tooth structure, it really doesn't matter what post we use. But remember too, I mean, underneath an all ceramic restoration, we don't want something that's very flexible. I showed you that photo that was on the box of these fiber posts where the entire crown preparation was composite resin and a fiber post. That's a very unfavorable foundation for an all ceramic crown. All right, how about the stress concentration of the occlusal forces by metallic posts that is overcome by fiber posts? Well, we looked at the literature. Sagerstrom's study, we had 14 fractures. We had 35 teeth that were extracted. And of those ones that were extracted, 14 were from fractures. So I'm not so sure that they dissipate forces the way people think.
Dr. Stevens, sorry for interrupting you.
Yes?
The amount of questions are too many, so it's really up to you if you want to answer that much of questions.
All right, we can
whatever time you want to stop, just let us know.
Yeah,
the time is yours, okay?
Yeah, we can stop.
If you want to stop right now?
Yeah, we can stop.
Sure, okay, doctor. Whatever you want. Thank you so much for your time and your efforts, really. Dr. Sami, can you join us, please?
Sammy?
Anyhow, before Dr. Sami comes, this question, as you can see in the screen in front of you, you can go to our Twitter account and answer this question that was put by Dr. Stephen Morgano. Don't forget to reply in the same tweet and also to vote for the right answer. Dr. Sami, do you hear us? Don't forget to unmute yourself, Dr. Sam, before you talk.
Yes, hello.
Yes, sir.
Dr. Morgano, thank you very much. We're really sorry. The amount of questions are so many. I'm sure everybody enjoyed the lecture as much as I did. It's really a pleasure to see you again, even if it's over the internet. But I'm hoping we meet soon, inshallah. And we thank you again for this opportunity. It gave us a lot of pleasure. And I'm not sure about the number of the audience, but I think the server is crashing from how many people attended. We really thank you again, and we hope to see you again soon, Dr. Morgano.
Okay, thank you, Sammy. When this is all over, you have to come visit New York. And I'll show you.
As soon as they allow traveling again, I'm sure we will.
Yeah, and I'll show you my school.
It will be a pleasure.
Okay. Well, good night, everybody.
Thank you very much, Dr. Morgano. Bye-bye. Bye.
So, dear audience, we hope to see you again tomorrow at the same time, 8 p.m. with our next speaker, Dr. Abir Haddadi. Thank you so much for your interest in attending our webinar session. Stay safe and have a great night. Bye-bye.